To order. Here comes that virtual gavel. Oh, sorry. No worries. I remind everybody, but mostly myself, that today is March 10th, our Public Employee Benefits Board meeting. And good morning to you all. It is great to see staff members in the room here in our large conference room, and those of you on screen, and welcome to the public who is listening in. COVID-19 and the Governor's Proclamation 20-28, we are meeting today via Zoom only, which we will do until further notice. What I'd first like to do is board member introductions. I'm going to do a roll call to identify the board members who are with us today. And as usual, Harry, I'm going to start with you. So Harry Bossy, are you on?
Yeah, thanks, Sue. It's Harry. I am on.
Good morning. Thank you. Yvonne Tate. We're not with us yet. Okay, we will watch for Yvonne and we will announce that if she joins late. Elliot Weinstein.
Present.
Thank you. Scott Nicholson.
Present.
Thank you. Thanks, Scott. And then Tom McRobert.
I am here.
Thank you, Tom. Love that baseball cap. John Comerford.
Present.
Hi, John. And lastly, Leanne Coonsey. Leanne is not with us yet either, but oftentimes slips in. So we will watch for those two board members. Also, Michael Tunick from the Attorney General's office, are you present?
I'm here.
Thank you. And as you all know, I am Sue Burge. I'm the Director of Healthcare Authority and lead the PEB board and chair the PEB board. With both board members and presenters attending virtually, it's helpful for the board to hold their questions until each presentation is done, or when the presenter pauses and asks if there are questions. Board members, we will also watch on screen in case you use your Zoom raise hand feature or your manual hand. So we'll be watching to indicate if you have a question. If we can't see you and you are really feeling like we left you behind, please don't feel bad about interjecting. But we will all try to monitor that closely. For the public, you'll have the opportunity to provide general comments at the end of the meeting during the public comment period. What I'd like to do now is ask Dave to give us an overview of today's agenda. Dave, you ready?
Yes. Good morning, Chair Birch and members of the board. We're going to start off with legislative session is ending today, so we'll give an update as to where things are in session, both from a bill perspective and a budget perspective. Then we have several resolutions to introduce to you. This is the initial introduction. Per the operating procedure we try to hold to as much as possible, we'll introduce today and then ask for action at the April board meeting. But we have, I believe, 4 resolutions for you today that are eligibility and enrollment related. This is so that we are able to then meet our rulemaking timelines as an agency. Then we will move into a couple of informational and discussion presentations, starting with the UMP pharmacy benefit management update. There were some changes in one of the vendors that is used as part of the UMP pharmacy benefit. That changed in January, and we gave some previews of that at the end of last board season, and we wanted to let you know some of the impacts of that transition that happened a couple of months ago. And then I'm excited to have the beginning of what I envision as a 3-part mini-series of discussions related to potential benefit design changes to the Uniform Dental Plan, with an eye towards 2024 at the earliest for those types of changes. But that discussion hopefully begins today and is a topic for much of our board season. And then we will end the board meeting with a conversation about brainstorming and looking at future other benefit design changes that you'd like the agency to look at. This was something we envisioned happening at the retreat, but we just ran a little short on time with some of the other topics, and so we'll have that today. So that's our board meeting today. I did want to highlight that the backdrop that we're using as an agency today is snow-covered Mount Rainier. For those of you, many people misidentify it as Mount St. Helens. It's just an odd view of Mount Rainier, but it is Mount Rainier that we're looking at for our natural beauty today. And if you don't mind, Sue, I will just go into my next part, which is the follow-up from the January retreat. There are a couple of questions that came up at the retreat. There were 2 that related to Annalisa Gellerman's healthcare cost transparency working on to be able to give some slides to answer those questions about certain spending trends and some comparisons with a couple of other states. So I'm envisioning bringing those back as slides in my follow-up at the April board meeting. The questions that I do have some insights on today, there was a question during the demographic presentation about what the median income state tax rate is. And the specific answer, this was, I believe Tom asked this question, is that the 16% of median income goes to state and local taxes in our state. And that percent obviously goes up or down depending on your relativity to that median income, which is something that we were describing in the presentation at the retreat. But I think, Tom, you were trying to learn a little bit more about the relativity of median income, and so it was 16%. The next question that I had with some insights was Sue asked for the COBRA subsidy, what was the total amount that was spent by the federal government in our populations to support that COBRA coverage. And over the course of that 6-month expansion and coverage period, it was a little over $2 million that was received or paid on behalf of the federal government rather than the COBRA enrollees self-paying that amount. So it was about $2 million that was realized in our programs alone. And then the last question that I had, John Comerford had asked, when we batch the board correspondence and the materials that we send in advance of the meeting, there was a question about, could we provide some insights about the resolution of those matters? We did a first run at that the past packet that was sent on Friday with just some brief kind of synopsis. We have to be careful about oversharing potentially protected health information, but trying to give some context. It's still a work in process. I don't think we've quite landed on the final version of it, but I hope that the board members saw that there was at least a first attempt to try to respond and give some more insights as to the resolution on those correspondence issues. So a work in progress, but appreciated that that was an important request from the board, and we're committed to continuing to try to give some additional insight. So those
Thank you, John. Thank you, Dave. Thank you.
Yep, absolutely, John. So I would see if there's any questions about any of the things that I presented on.
Dave, not a question, just a comment on the COBRA amount of $2 million. I just wished for you to convey to staff that that's pretty extraordinary to think about how we channel those federal dollars out to our population of folks. And kudos and thanks to them. That was turn on a dime. They pivoted fast. They made that happen, and doesn't always happen in many other states. So thank you for all these types of questions.
Great, and that's what I have as the update.
Okay. Any other questions for Dave? Those issues. All right. We're going to move on to the next agenda item, which is the 2022 legislative session. Kate Walker, who is our Executive Special Assistant to the ERB Division, is going to provide an update on the legislative session, which ends today. As Dave said, we're all celebrating. And Kate's materials are behind tab 3 in your materials.
Good morning. Good morning, Director Birch, Chair Birch, and members of the board. Cade Walker here to present on this, the last day of the 2022 legislative session. It's been a whirlwind of a session, a short session this year that began shortly, just about when we had last met for the retreat. And here we are at your first regular board meeting, and we are at the last day of session. So it has flown by. For some of us, and for some of the other of us, it has been a bit of a slog, but a quick session this year, and quite a bit of interesting things that have happened. But for the most part, the ERB division, that is the PEB and SEB programs, were unscathed with much to do, minimal report requirements, and other things that have come out of session. So, but we'll dive in and give you an update of where we're at as of today, which is the last day of session. Next slide, please. So as always, want to kind of make sure that acknowledge all the work that goes into the legislative session from our division. Our division has approximately 20 to 25 analysts. These are subject matter experts in their respective areas. that are assigned bills based on what they have a background in. And oftentimes it's just someone who is going to be capable enough of looking at a piece of legislation that no one would have any expertise in necessarily within our division, and they go through the process and analyzing it and comparing it and seeing how it may impact our lines of business. So this year we had a good number of bills that hit us at the very first of session, and then it kind of slowed down and we saw a lot more engrossments and substitutes and the like. So at the end of the day, we ended up with about 165 analyses total, which is fairly light for a short session at the end of the day, but I think it's been a successful session for us. So next slide, please. Here's our cascading waterfall of the progress of bills. Again, this was as of last week. We had 5 bills that we had designated as a high priority that the ERB division was leading the analysis on, that had made it all the way through to the opposite chamber, meaning it was just at the cusp of once it gets voted on by the opposite chamber, then it gets signed and sent over to the governor for the governor's signature. Of course, now with today being the last day of session, action has been taken on all 5 of those pieces of legislation, and I'll cover some of those in a moment. Next slide, please. First, we want to acknowledge that 1052, this was legislation that was first introduced last year. It was introduced by, or at the request of the Office of the Insurance Commissioner, in regards to some aspects of the insurance code that didn't align with the practices that the industry had, as well as our programs had, in having performance guarantees in our contractors with health plans. So I think I've talked about this at every board meeting since last session, but this year it did pass. It has passed on to the governors for signature, and it may have already been signed by the governor because it did pass, I think, over a week ago. So we're very relieved that this made it through session this year. Last year, it didn't make it through session just because it didn't make it onto the floor for a vote. There was no negative vote against it in the entirety of its process through the legislature. And so we're very relieved that this has made it through and will likely be signed by the governor if it hasn't already, and allow us to continue the course of action we have in our contracting as we currently do. The ESD bills that we had also been tracking, these were this pair of bills that were going to require that the non-represented educational service district employees who otherwise, as of 2024, would be required to participate in the PEB program. This was a bill at the ESD's request to require that those non-represented employees participate in the PEB program. They felt it was more advantageous to them or more aligned with their work patterns, or any number of reasons why they wanted to have their employees in PEB. However, those pieces of legislation did not make it past certain cutoffs and died this session. However, there was one other ESD piece of legislation that had very nominal or no impact on the programs, but it was a small piece of legislation that required full funding for represented employees in the ESD's represented employees would be fully funded by the state. It's a little different just because of the way that educational service districts, or ESDs, are funded. And there's only about 100 or so represented ESD employees, and they are currently participating in PEB, and they are within just 2 of the ESDs. So we had tracked both of those just because that would have implications for members that we serve. And so that did pass, but it didn't have any other implications on either the PEB or PEB programs. It was purely a funding bill for some of those, for the represented employees in ESDs. I think that's maybe a little convoluted, but I just wanted to mention that that we had been tracking that all along. The bills for the retirees that would expand the definition of separated employee to include retirees coming out of Plan 2s from either the TERS, PERS, or SERS systems. None of those did make it. This is the first time I think we've seen that particular piece of legislation. So it's assumed that we will see that again in the future. And I think we can continue to have conversation and provide additional feedback on that legislation next year. But we had been tracking that, and it just did not make it out of, I think 5,700 had made it a little bit further the House, but did not make it through the House. Next slide, please. Into some of our topical areas. We always have a good slate of pharmacy bills that we track. This year, 5610 RX drug cost sharing, that did pass. That is legislation that requires that when in general, and there's probably a lot more nuance to it, but I'll just try and give you the quick elevator speech on it. 5610 requires that when there is a rebate or a coupon or some other entity that pays a portion of the cost share for a member for a prescription drug, that portion that's paid by a third party, whether it's a manufacturer coupon, which I think is generally what they're referring to as manufacturer coupons, that amount is applied to the deductible for the member. We're following that a little bit closer. There is a minor amount of potential financial implications for us over a long term, but there wasn't any substantial costs that we had noted from our from MODA when we had them review the legislation. So we'll continue to see the implementation of that legislation. I think it would be appropriate for me to turn a little bit of attention over to a bill that I'm quite confident that Elliot has been very interested in hearing about, and that is Senate Bill 5532, and this is establishing a prescription drug affordability board. This is, I think, a bit of a longer time coming, and I think we've seen iterations of this bill in the past, but this did pass this year, 5532, and it creates, as the title describes, the Prescription Drug Affordability Board, which will be a 5-member board appointed by the governor to look into the pricing of pharmaceuticals. Now, I think the board is authorized to begin its work after HCA conducts a report that will be submitted next year. I think it's January or June of next year on prescription drugs and cost transparency. And then the board can begin its work of reviewing the cost of drugs, and they have some parameters. They have parameters that are, when they want to review any particular drug and kind of dive into its pricing, there's certain things that drug it needed to have been on the market for so long, depending on what type of drug, if it's a name brand or generic, the pricing of that drug, whether there's been a significant price increase in that drug in the last year. And so certain factors the board can then consider in applying a more strict review of that drug and looking into it further. They're allowed to do up to, I think, 24 different drugs a year that the Affordability Board can address and conduct a review on. And then depending on the findings of that review, establish certain pricing criteria and even has some penalty authority, some authority to assess some fines. The board and HCA have some authority to assess some fines. So it's going to be really, I think, intriguing to see what work this board does over the coming years. Certainly going to be something that will help provide some much needed transparency in that space. I wanted to stop and just kind of pause and see if there's any questions so far on the legislation that's passed.
No, you've done an excellent job. There's one question I do have. There's something like the bill has to cost $60,000 a year. Not the bill, I'm sorry, the drug. Can you comment? I mean, do I understand that correctly? I may not.
I think it is. So there are different criteria depending on the type of drug. I mean, if we're talking a name brand drug, my understanding is that for name brand prescription drugs that are introduced with the price of over $60,000 or more per year for the course of treatment, or if drugs have had a greater than 15% increase year over year or in a 12-month period that it's a name brand drug. So it kind of breaks down the review criteria based on whether it's name brand, the price at introduction, which I think that certainly seems to be hinting at the type of drugs like the hepatitis C drugs, Solvati, those type of drugs that came out and had a significant initial cost for the course of treatment. So for name brand, there were different thresholds. That $60,000 threshold being, I think, the introductory price, or for a name brand drug that saw a 15% price increase in a 12-month period. If there were biosimilar drugs, they had different criteria. So if they had an initial price that was less than a certain percent, maybe I think it's 10 or 15% less than the reference brand price. And then for generic drugs, if any of the generic drugs were costing more than $100 a month, or they saw a more than 200% increase in the price in a 12-month period. So it really depended on the type of drug, whether it's brand name, biosimilar, or generic. And then there were different criteria based on the amount of increase in the cost of that drug in a 12-month period, or the price of that drug upon its initial introduction, or just its price in general in the case of some generics. So it really broke it down a little bit more than just having to be a $60,000 price tag.
The other thing, if I understand it correctly, and I really appreciate this because I've been waiting for you to explain this to me. I've been tracking it for the whole session. There's also something, the drug has to be on the market for at least 4 years.
I think there are different timelines. I've seen, for some reason, I'm thinking 7 years for certain retail specialty or mail order.
Right. You may be right.
And then again, I know for like the name brand drugs, if it has an initial price, it's introduced at more than 60,000. So there's a whole rubrics, and I'm sure as the board forms the rubric for which drugs are qualified for being reviewed and what those criteria are will be a little bit more easily spelled out for those to see kind of those criteria.
Thank you. I was very concerned about this bill because it might be able to bring down premiums, because the staff alerted me last year to the connection between premium costs and specialty drug costs. Thank you so much.
You're welcome. And it may be something that Dave may be able to have somebody come, maybe not this year, given that the legislation just passed and the initial report's not due to next year, but I'm confident that in time to come, there will be ample opportunity to bring our pharmacy staff on to talk more about the actual implementation of the beginning of the board and the report, and certainly pharmaceutical drug costs will be a topic for the board in perpetuity.
Thank you so much. I really appreciate this.
You're welcome. Okay, so moving on all the pieces of legislation. Oh, sorry, go ahead.
I have a question, but before we move to Tom, Elliot, one thing I think is really important to note, just like the cost board, think of it like a needle in a haystack. If the legislature wants these groups to be effective, they're trying to give them parameters to shine the light into the kind of darkest areas or the most problematic areas, because many of these boards could wander for years and not get to the heart of some of the biggest issues where we can try to create cost containment strategies. So, Chase, thank you for that important background, and I believe there were a fair amount of concessions still made, but we got more movement in the pharmacy area than ever. I believe Tom had a question and is next before we move on, Kate.
Yeah, thank you, Sue. Cade, House Bill 1052, where it talks about performance guarantees. Can you give me a little more information about what exactly performance guarantees are and what the implications of that are?
Yeah. If I were to be really blunt about it, it's kind of what allows us to hold the health carriers' feet to the fire for performing in certain metric areas that we have contracted with them to perform in. For example, the time it takes for their call center to answer our members' calls. We have metrics that have been established in contract that say your call center will answer 90% of our phone calls. And I don't know if this is the actual term in the contract or not, but it'd be something to the effect of the region's call center will answer UMP members' calls 80% of the time within 30 seconds. And so we want to make sure that the call centers are performing at a high standard. And if they fail to meet that standard, then there's a financial penalty that's paid by the carrier for failing to meet that performance guarantee. It may be other things like call center is an area that we do touch in quite a bit. I just want to make sure our members are able to reach the call center to get assistance from the health plan timely and without having calls dropped. It may be other things. Dave, do you have any
examples?
Yes, please.
Yeah, Kate, some other examples would be claims adjudication timelines, accuracy of claims adjudication. So those all then trickle down into explanation of benefits that members see, but making sure that there's timely and accurate processing of claims. Some of our vendors have website metrics for how much the time and duration capabilities of their website being available.
Another example, Tom, is like primary care network adequacy. So if they say Dr. Smith, just using that name, has a practice that's open and is seeing patients, but our people call and they say, you can't get in for a year. We have performance guarantees that that things have to run a certain way. That help?
Yes, very much. So also, Dave, going back to your example, so if I'm Dr. Jones and I submit a bill and I'm not happy with how quickly I am reimbursed, would that be a performance guarantee that I could look at?
Well, the provider wouldn't look at that, but we would have something like over each quarter, again, like Kate, I don't know the exact percentages, but it might be like 97% of claims will be adjudicated within X number of days. And then there's also a separate performance guarantee on the accuracy of that claim being adjudicated. And so that would be something that we are monitoring across, their entire performance in a, usually a quarter or annual basis. It depends on the performance guarantee. So one individual late claim wouldn't necessarily trigger the PG, but it's kind of like I said, there's usually something like 97% or 98% must be done within 20 days or 30 days. Another example would be life insurance, the processing of a life insurance claim, the medical underwriting processes within long-term disability and life insurance. Those are others. The processing of a reimbursement of claims when a paper form or reimbursement instead of a card is swiped for FSA or DCAP benefits, all of those types of things. But they all have a little bit of wiggle room for, sometimes mistakes happen, and there's just kind of day-to-day things that, it's not about perfection, but it is about solid performance. So there are instances where, something doesn't meet our expectations, wouldn't be a perfection standard, but our performance guarantees don't demand perfection.
But we also have like a whole appeals process. So if that doctor wasn't getting paid, or if there's a kind of a conflict resolution process that these guys have guarantees, or I call them service level agreements, where we demand a certain standard, a certain service threshold. So Dave's absolutely right. All these fall into kind of that threshold that we can monitor this contract. And it really helps the team hold our TPA very accountable to what they're paid for.
And we have performance guarantees on meeting the timelines for the appeal process.
Right.
So there's performance guarantees all over the place. And we have these in our contracts with Regents as the TPA for UMP, with Delta as the TPA for the Uniform Dental Plan, with Standard for long-term disability, with MetLife for life insurance. All of our contracts have performance guarantees in them. And this bill is just solidifying that when we collect on a performance guarantee, that doesn't run afoul of the insurance code, which there were some concerns that there were some technical violations that were happening in the rate filing process by the healthcare authority's collection of these. And so this bill just tidied up that the historic practice that is done is fine, and performance guarantees are actually expected of state agencies, and it was just kind of aligning the insurance code with the performance-based contracting process that state agencies are required by state law to do.
And Tom, just
Thank you.
I think one last little thing for you, Tom, as I heard your question. It's the 1052 allows for large group employers to utilize performance guarantees in their contracting with insurers. It's not something that is, this bill does not address the ability for providers to have any sort of performance guarantees in their contracts with carriers themselves. This is purely for large group employers, the state, us, and other large group employers to implement, to have performance guarantees in our contracting with the healthcare. So I had heard your question if a provider had an issue with their reimbursement rate, that would be something wholly separate that this legislation is not addressing. It's purely the contractual terms between us as the large group employer, the holder of that policy, that contract, and the insurer and all the terms that fall underneath it, and our ability to have actionable efforts against failure to meet certain standards.
Okay, thank you.
Okay, thank you for the questions, Elliot and Tom. If there's nothing else, I'll continue on. Under the insurance kind of portion, 1688, this is a consumer protection expansion of the out-of-network billing, the surprise billing expansion. It is more closely aligning with pending federal regulations regarding surprise billing. So we're happy to see those important consumer protections that are expanding in our state. Next slide, please. Under some of the medical services, the two that did pass, 1689, it's biomarker testing. This is removing certain barriers to biomarker testing for certain cancer screenings. And then 5702, expanding access for donor breast milk coverage under plans so that infants are able to get access to important nutritional need that comes only from human breast milk and not from necessarily from formula. So we saw both of those pass. All of the piece of legislation that we saw pass, there are some minor potential fiscal costs. Whenever there's any sort of expansion of services, there's always going to be a potential for increase of costs, as there's now other services that are going to be covered. But in our plans reviews of the legislation, these all had fairly nominal costs that were all incorporated and articulated in our fiscal note process to the legislature, and we've not had any concerns about the funding of those, although we'll continue to review with the conference budget and I think Tanya's comments about the budget that are forthcoming. And with that, I think that's the end of my presentation. So
this is Elliot. There's just one other thing I wanted to add. I'm very gung-ho about this stuff. 5642. I've been tracking that one too, and I believe that keeps the price of insulin low. I think there's a ceiling on how much can be charged, and I think it's around $35.
Yeah, so yeah, there's the price of insulin, insulin affordability, 5546. And it did pass, it has been signed. And let me pull real quickly, I can tell you, it limits, so the prior limit that was set in 2020, there was a $100 a month limit for a 30-day supply of insulin, and that limit was to expire on the 23rd or January 1st of 2023. This new legislation beginning 2023, health plans must cap the total amount of a 30-day supply of insulin at $35. So yes, that $35 is correct, and that will take effect January 1, 2023, and will expire January 1, 2024. So it's a 1 year. So we'll have to see. They'll need to take action on it again to extend that amount or change it. So we'll expect to see that again next session, so they can address that for the next year.
Thanks, Kate. I really appreciate your explanation.
You're welcome. With that, any other questions?
Kate, I think Leanne.
Yes.
Oh, Leanne just joined, so I just want to welcome Leanne. And Leanne, we just finished the legislative update. And Kate, thank you. I don't see any other questions, so I think we're going to move on to the next agenda item.
Great. Thank you, Reverend. I also want to thank all of the analysts and everyone this year that have helped put in a lot of work. A lot of hours go into reviewing things in our division and our agency. It's extra work that we take on to make sure that we're doing a good job. So I just want to make sure all of my analysts
Take it away.
All right. Good morning, Chair Birch and members of the board. For the record, my name is Kate LaBelle, and I'm here to provide an update on the supplemental budget on behalf of Healthcare Authority's Financial Services Division. Next slide, please. Just as a friendly reminder, our funding rates are set per eligible employee per month. The current fiscal year 22 funding rate is set at $936, which remains unchanged in the proposed budgets. The funding rate for fiscal year 23 in both the governor's proposed budget and the House proposed budget is set at $1,130 per month and is set at $1,184 in the Senate proposed budget. While we have not fully analyzed the final conference budget, which was released less than 24 hours ago, I can tell you that the fiscal year 23 funding rate is set at $1,130, which aligns with the governor's proposed budget as well as the House proposed budget numbers. While the funding rates are different between the versions of the proposed budgets and the final conference budget, the Healthcare Authority has no concerns in the underlying assumptions used to derive the funding rates. Both the proposed funding rates are adequate to maintain the current level of benefits, plus a few additional items that I will walk through on the next slide. Next slide, thank you. These decision packages should look familiar because Tanya did discuss them in the retreat in January. The funding remains consistent in all three proposed budgets as well as the conference budget. The first item is for customer service funding. This funding provides funding as effective July 1st, 2022. This will allow Healthcare Authority to better serve our customer needs and address the ongoing program complexities. It includes 9 FTs in total, 8 of which are for our annual management. Both the dollars and the FTs are actually split between the PEB and SEB programs, and the PEB portion of the funding for the first year is $604,000, and the ongoing funding is $562,000 per year. The next decision package is for procurement resources. This decision package is to re-procure for our existing contracts within our PEB and SEB programs. The examples of these contracts include our wellness and our dental contracts. Funding for the PEB program for the first year is approximately $1.4 million. The third decision package, which again should look familiar because this was presented during the retreat, is funding for our mental health parity. The total funding is $700,000, which is split 50% between each program. The ongoing costs are $100,000 per year. This funding is to complete an analysis of mental health benefits in the Uniform Medical Plan and implement necessary changes to meet federal requirements. In addition to these 3 decision packages mentioned, both the House and Senate include language that allow for the continuation and expansion of our digital point solution for behavioral health. This adds and expands virtual options for behavioral health within our Uniform Medical Plan for both PEB and SEB, which will increase or could increase member access to early behavioral health interventions. The PEB portion of the funding is approximately $300,000. And I'll pause there just in case, Dave, if you have anything to add.
No, we're just, the only thing I'll add is the customer service staff that we're looking at, that directly relates to the, our efforts to increase the timeliness of response times for people who call on the phone, which is something that I know is an often talked about topic, because there's always a flood of calls, especially at key parts of the year, and we just wanted to expand the staff there. So that staff is available as of July. Now we'll need to hire and train them, so the rush will be on to be able to have as trained as possible folks for the fall 2022 open enrollment. But there is light at the end of the tunnel for some additional customer support staff, and it's not a train, it's helps on the way. So that's the good news there.
Yeah, I also want to add, for the board's understanding, that we're going into a highly volatile eligibility period, because if you think about what's about to come upon us, in the Medicaid program, there are 300,000 people that had to stay on during the pandemic that have to be re-reviewed and may have become state employees or may have become school employees, and there's going to be a lot of confusion. We also have likely about 5,000-ish refugees that are likely to be welcomed into Washington. We have another 200,000 undocumented. We have significant changes in eligibility policy on Medicaid. All of this means that you could have almost a 750,000 people kind of confused about what's going on the eligibility scene. It will impact our call center. It'll impact our Medicaid call center more, but oftentimes people confuse HCA. No matter what, they get confused. So I want to do a shout out to Dave in the call center, staff, and to make sure the board understands that all of this, it's going to be a little bit like the ACA beginning all over again, because I think people get confused. So I just want people to understand that. Elliot, I think you have a question. You're muted, Elliot.
Do you think that the Medicare direct contracting program will have an effect on this too?
Elliot, great question. There's a lot changing in the D-SNP arena and with some of the Medicare things. So again, it all is confusing to everybody because, you know, they just want to see their doc or know what hospital to go to. So I personally think it will lead to more calls, but Dave works very closely with our other call center leadership, and I'm confident that we are best positioned for as good a customer service as we can with a deluge of activity that's about to come. So I remind everybody to just have to be patient, and we will try to get to people as quick as possible and meet their needs. And our partners, regions, Permanente, Primera, everybody is kind of pulling in the same direction of trying to help people navigate. We're as best positioned as we possibly can, and we thank the legislature for the resources that they did. Yeah, I don't see any other questions. Kate, back to you.
Awesome. Next slide, please. So this slide pertains to the Medicare explicit subsidy, which is the amount that the state contributes for Medicare retirees per month towards their PEB healthcare premiums. The subsidy remains $183 or 50%, whichever is less, in all versions of the proposed budgets, as well as the final conference budget, which was released yesterday at 3 p.m. Next slide, please. The House proposed budget also includes language that requires the Healthcare Authority to conduct a study of the Uniform Medical Plan and provide a report by June 30th, 2023. This report must include an analysis of administrative services and associated costs provided prior to 2010 and those that have been procured since, and also details of what business the Healthcare Authority could conduct itself or through discrete provider contracts. This report also requires HCA to analyze assumptions on claims impacts and performance guarantees. Lastly, this report requires the Healthcare Authority to include an implementation plan to outline how the Healthcare Authority could resume the administration of some or all services for the Uniform Medical Plan at the end of the current third-party administrator contract. And I would also like to note that this language, this proviso language, was included in the conference budget that was released yesterday. Dave, do you have anything?
Actually, Tom, is your question about this proviso language, or is your question about the last slide, the subsidy?
No, it's about this. Go ahead, Sue.
Go ahead. Oh, go ahead.
Okay. So the previous slide, it said to maintain, enhance, or replace current contracts. Is this this proviso right here? Is that? I'm sorry, not the Medicare. Yeah, the one before Medicare explicit subsidy. I'm sorry. Yeah. Procurement resources. Funds are requested to maintain, enhance, and replace contracts within the PEB program. And is this study, is that basically what they're going to be doing? I know that, for example, prior to 2010, the Healthcare Authority actually administered healthcare and then it was taken over by Regents. So I'd like kind of a better picture of what this study is supposed to do. What is the goal? Are they actually looking at going back to, for example, is that one of the things the legislature is looking at, is perhaps having the healthcare authority resume some of the things that they did prior to 2010?
I'll take that. There's a couple of things to unpack with your question. First, the bullet of procurement resources of $1.4 million on slide 3 is not related to slide number 5. Procurement resources on slide number 3, we have, a couple dozen contracts that we manage out of the PEB and SEB program, and they are all kind of on a periodic cadence. And so some of them have an end of life, and per state procurement, we need to go out for procurement on a regular basis. And so this is just kind of the natural occurrence of events of some contracts reaching their end of life. The UMP TPA contract is not one of those that's up for a procurement in the next 2 to 3 years. An example of a procurement that's part of the procurement resources decision package that was funded is our wellness contract. Our vendor contract for the portal that's used for Smart Health has an end of life that we are gearing up for a procurement on. So that's an example of just one of our day-to-day contracts that is up. We actually did a very large procurement for the UMP TPA contract. That work actually began in the agency somewhere around 2015, culminating in a contract that went live on 2020. So that was a 4 to 5 year procurement process. If we go to slide 5, this budget provision is really looking at saying, there were services prior to 2011 that the healthcare authority directly administered for the Uniform Medical Plan that in 2011 were contracted out for the first time. The winner of that procurement was Regents, and then the winner of our most recent procurement was a new contract with Regents. But it is saying to look at the services that were provided prior to the TPA contract and identify if there are pieces, some or all of that work that might move back to the healthcare authority for direct administration rather than through a third-party contract. So an example is provider network contracting. The healthcare authority used to directly do provider contracts with hospital systems and providers for the network for the Uniform Medical Plan. But in 2011, part of the TPA contract was having Regents or having a TPA do those provider contracting instead of staff at the healthcare authority. That's one example of something. Claims administration is an example that some folks often ask, but it's important to know that even before 2011, the healthcare authority didn't do claims adjudication and administration directly. Even that had a prior TPA. So there's a lot of unpacking to do of what services were previously provided, what services are now provided, and what could a future state be. This this budget provision language has a report due on June 30th, 2023, because that's the latest date that the budget bills can only require things during the 2-year budget period in which they apply. So this budget bill ends the authority for it ends June 30th, 2023. That's why the report is due the last day of that budget cycle. But I think the thought process is that this report could be looked at and we'd see if there is future interest from the legislature in transitioning resources back in the future to HCA, which would require additional staffing or infrastructure built, and that's a multi-year process. It's important to know that the current contract with Regents has an end date of December 31st of 2029. And so while it might seem early to talk about this in 2022, it really isn't, because as I started my comments, the procurement that led to a 2020 contract started in 2015. So if there is any sort of directional difference that the legislature wants to put us, the agency, on a path to do more of these administrative services, this is a timely discussion to be having.
Thank you for that. I want to assure the board that there are so many moving parts to the transforming healthcare landscape that we've seen. When we procured years ago, there was no public option. There's more dual coverage. There much more going on with pharmacy cost containment and cost containment. There's so much more alignment going on with our different purchasing strategies, how we use centers of excellence, and the way we are all aligning about primary care. The infusion of behavioral health services that the pandemic is really necessitating now, a way that we really further integrate behavioral health. And all these things have to be looked at vis-a-vis what's the best modality. Should government take on and administer some of these pieces? Should we be outsourcing? And so I think it's fabulous that we have some time to begin these conversations, and we'll continue back to the board. Exciting that the legislature really is kind of trying to get us thinking ahead about, could we continue to drive towards greater healthcare cost containment, in line with also the Healthcare Cost Transformation Board? Where do we get the best deals, the greatest value? What's the best structure? And I remind you too that the Universal Health Task Force is in flight, and with the legislature's clear signal about covering undocumented, they have already subsidized the Cova Islanders, bringing on school employee boards. All these things play out with how people are insured or co-insured, double coverage. Yeah, it's a very interesting landscape of things that are shifting. Exciting committee to take back to you, I think.
All right.
Other comments, board members.
Thank you. Well, this was actually my last slide. The next one's just my question slide. So if there are no other questions, I will hand it back.
I am not seeing any other questions. Thank you, Kate, and we'll move on to our next agenda item. So the next agenda item is policy and rules development. And Stella Nye is our policy and rules coordinator. And they're going to introduce 4 proposed resolutions for the board's review, and their materials are behind tab 5. Stella and Emily, I butchered your titles, but I think everybody knows you. We're so familiar with you. Welcome and carry on.
Good morning, Chair Birch, members of the board. For the record, my name is Stella Ng. I'm the Policy and Rules Coordinator for the PEBB Division. Today, Emily DeChain and I have 4 proposed policy resolutions being introduced. Next slide, please. This slide and the next 2 slides are included in the presentation, so you will have them available as you consider the policies we will discuss. Slide 5, please. Here are the 4 proposed resolutions being introduced. The first resolution would address allowing more retirees the option of enrolling into the Medicare Advantage with prescription drug plan by addressing the gap months. The second resolution would address deferring PEB retiree insurance coverage when the subscriber becomes eligible for the employer contribution. The third resolution would address employees returning to work from active duty, and the final resolution would address dual enrollment situation. I will go over the first 2 resolutions, and Emily will go over the last 2 resolutions. Our goal today is to introduce these policy proposals to the board, get your initial insights, and prepare the board to take action on these resolutions at the next board meeting. Slide 8, please. The first proposed resolution, PEB 2022-03, Medicare Advantage prescription drug plan enrollment during gap months, is to address the gap months before a MAPD plan begins. Currently, we have 2 MAPD plans through United Healthcare available to our retiree population. These plans require prospective enrollment because federal rule does not allow retroactive enrollment. Under our current rule, when a subscriber elects to enroll in an MAPD plan and does not submit required retiree election forms before their PEB retiree insurance coverage begins, they would have to wait till the annual open enrollment or a special open enrollment to enroll in an MAPD plan. This proposed policy would allow our retiree population to enroll in a uniform medical plan Classic during the gap months before their MAPD plan begins. And the proposed resolution reads, if a subscriber elects to enroll in a Medicare Advantage prescription drug MAPD plan, and the required forms are received by the PEB program after the date the PEB retiree insurance coverage is to begin, the subscriber will be enrolled in Uniform Medical Plan UMP Classic during the gap months prior to when the MAPD coverage begins. And we have 3 examples to illustrate this policy proposal. Next slide, please. Example 1 talks about Joan requests to enroll in a UHC PEB complete plan for her PEB retiree insurance coverage. Joan's retirement date is July 1st, 2023. The PEB program receives her retiree election forms on August 17th, 2023. For medical, Joan selected United Healthcare PEB Complete, a Medicare Advantage prescription drug MAPD plan. Because Joan's enrollment in PEB retiree insurance coverage must be July 1st, 2023, which is consistent with her retirement date, and enrollment in the MAPD plan must be prospective. There is 2-month gap in coverage. Which plan is Joan enrolled in during the gap months? Joan will be enrolled in the Uniform Medical Plan Classic for the months of July and August before United Healthcare PEB Complete begins. And the second example, next slide, please. And example 2 is a retiring employee requesting to enroll in the MAPD plan after their current Kaiser coverage ends. George is currently enrolled in a Kaiser Foundation Health Plan of Washington Classic plan, and his retirement date is July 1st, 2023. The PEB program receives his retiree election forms on August 17, 2023. For medical, George selected UHC PEB Balance, a Medicare Advantage prescription drug plan. Because George's enrollment in PEB retiree insurance coverage must be July 1st, 2023, consistent with his retirement date, and enrollment in the MAPD plan must be prospective, there is a 2-month gap in coverage. So which plan is George enrolled in during the gap months? George will be enrolled in the Uniform Medical Plan Classic for the months of July and August before United Healthcare PEB Complete begins. And we have a third example, which is Francis, a retiring school employee requesting to enroll in UHC PEB Balance Plan. Francis is currently enrolled in a Primera Blue Cross High PPO plan, and her retirement date is July 1st, 2023. The PEB program receives her retiree election forms on August 17th, 2023. For medical, she selected United Healthcare PEB Balance, a Medicare Advantage prescription drug plan. Because Francis' enrollment in PEB retiree insurance coverage must be July 1st, 2023, consistent with her retirement date, and enrollment in the MAPD plan must be prospective, there is a 2-month gap in coverage. So which plan is Francis enrolled in during the gap months? Francis will be enrolled in the Uniform Medical Plan Classic for the months of July and I see Elliot has a question, has her hands raised. So
Yes, I have a gap in my knowledge. I'm relatively new, and I wonder, why is the gap plan always UMP? There must be some historic reason that I've never heard. It's just a lack of knowledge on my part.
Stella, would you like me to take that one?
yes, please, Dave.
Sure. So these 3 examples are showing what the world would look like if the resolution that's proposed passes. The reason that UMP Classic is being selected is it's the most comparable to the 2 United plans. When we introduced and recommended after the procurement these plan designs to the board, they were built off of the backbone, and the starting point was UMP Classic. So it seems the most natural fit if the member is intending to be in a United PEB Complete or I can't think of the other name, in one of the United plans, to put them in UMP Classic in this brief period. Again, we're kind of in this situation because federal law requires a prospective enrollment in MAPD, but UMP, again, is just the most comparable to the end state they're going to be in. So that's why our recommendation is the policy that leads all three of these examples to say UMP Classic for the 1 or 2 month gap period.
I think, Stella, you have a question first for Leanne and then John. I think that's the correct order. So Leanne, your question, please.
Thank you. So my question is, how it is the enrollment in the uniform medical plan for the gap months? It's done retroactively, right? Because there's no way you would know this since you didn't get the paperwork until August. Is that correct?
That's correct.
Okay. And then as far as cost, there's a significant difference between premiums. How is that handled?
The member will have to pay the cost of the Uniform Medical Plan Classic. I guess the member will need to be educated about the choice of plan during the gap months, because we're allowing this, if passed, this policy will allow more retirees to enroll in the UHC plan. So the intention of having this proposal is that members will not have to wait till the next annual open enrollment or the next special open enrollment to enroll. So they really will have to want to enroll into this UHC plan and be willing to pay for the cost of the Uniform Medical Plan Classic.
Okay, thank you. That answered, that looped it right back around to exactly what I was looking for, is that it is a choice, and it is the way to be able to get access to the retiree coverage sooner instead of having to wait. So I appreciate that. Thank you.
Thank you.
And you're spot on, and I would just share that this is actually an area where I get a lot of positive accolades about HCA, because potential retirees that reach out and understand the timing of all this and plan accordingly don't get caught in this bind because they kind of coordinate things with their retirement plans. It's those that don't, and this is why Dave also and our customer service team have a steady drumbeat of, hey, retirees, pending retirees, wake up and get a hold of us so that we can work with you. So I do want to just kudos to the team, because we really try to get people to be proactive, but we do have a good default action, even though it will cost them a little bit more. I think John was next, and then Elliot got in line. So John, your question, please.
Yeah, this is a little bit off of track, but it's a question I had. How many Medicare Advantage programs do we offer retirees? Just one?
We have 2 plans currently offer under United Healthcare.
And what percent of our retirees opt for Medicare Advantage versus a supplement?
So John, our current enrollment, the last time I looked, it's around 2% of the retiree population. So remember, this plan was introduced first for January 1st of 2021. So we've gone through 2 enrollment cycles. There was steady growth between year 1 and year 2, but we're still in the, it's still early in the product offering line, but it's around 2% of the population at this point.
And when you had added this to the program, what was your expectation, say after 5 years?
I think I'm going to have to follow up. I'm afraid that I'm going to mix up my numbers.
That's okay. It was just
We'll
point of information.
We'll put it up. I'll put that as a follow-up piece for next meeting so that I get the right numbers.
Thank you, sir.
Okay, thanks for that question, John. Elliot, you're next.
Yes, Dave, you touched on what I was searching for here. Why, and no one can answer for the federal government, so I understand if you don't have an answer. Why did the federal government prohibit these retirees from immediately enrolling in UHC? It doesn't seem to make sense. I don't mean it's you guys. Why did the federal federal government prohibit this?
So Stella, unless you happen to have any insights on that, we can put that as follow-up when we come back for the final action. But if you happen to have anything now, feel free to share.
I will need to do the research and get back to you, Elliot.
Thank
We'll
you.
put that as part of the info when we come back in April.
Thank you very much.
Spoiler alert, Elliot, I'm pretty sure it's because of some of the financial implications, that there were some safeguards put in place to advantage one side versus the other, but our diligent, capable staff will get back to us with a more objective answer.
That's why I'm always asking questions, because they do a great.
Coming, Elliot, that's what you're on this board for. Thank you. I don't see another further questions, so Stella, back
Thank
to
you. Thank you, Chair Birch. So the next policy proposal is on slide 13. So the second proposed resolution, PEB 2022-04, deferring PEB retiree insurance coverage when the subscriber becomes eligible for the employer contribution. We are bringing this resolution as a recommendation for the board's adoption. This policy aligns with how we are currently administering the PEB program when a subscriber becomes eligible for the employer contribution towards PEB benefits. When a subscriber becomes eligible for the employer contribution towards PEB benefits, their PEB retiree insurance coverage will be deferred at the end of the month prior to the month they're enrolled in the employer paid benefits. The subscriber will be exempt from the deferral form requirement. This policy proposal is necessary because federal Medicare rules require employers to offer employees over the age 65 the same benefits under the plan and the same conditions as any other employee under age 65. Even though we haven't had an incident where a non-Medicare retiree questioned the PEB program automatic deferral of PEB retiree insurance coverage when they became eligible for the employer contribution towards PEB benefits. This is how the program has administered the eligibility, because there is no financial incentive for them to self-pay PEB retiree insurance coverage due to high premium cost. We recommend the board adopt this resolution so the PEB program's practice of automatic deferral is uniformly applied to both Medicare and non-Medicare retirees. So the proposed resolution reads, PEB retiree insurance coverage will be automatically deferred when the subscriber becomes eligible for the employer contribution towards PEB benefits. The subscriber will be exempt from the deferral form requirement. And we have an example to illustrate this policy proposal. Next slide, please. Thank you. Charlie is a retiree enrolled in PEB retiree insurance coverage. On March 1st, 2023, Charlie is rehired as an employee at the Department of Licensing and becomes eligible for the employer contribution towards PEB benefits. When is Charlie's PEB retiree insurance coverage deferred? Charlie will be exempt from the deferral form requirement, and his PEB retiree insurance coverage will be automatically deferred on March 1st, 2023. Charlie will be enrolled in PEB benefits as an employee effective March 1st, 2023. Now I'll be glad to answer any questions the board may have.
Any hands up? So Stella, back to you.
So if the board has no other questions, I'm going to let Emily go over the rest of the policy resolutions. Thank you.
Welcome, Emily.
Thank you, Stella. Good morning, Chair Birch, members of the board. Good to see you again. For the record, my name is Emily Duchesne. I am the regulatory analyst in the Policy Rules and Compliance section for the PEBB division. Today, I have two proposed resolutions to introduce. One is a proposed USERRA policy resolution, and the other is a proposed dual enrollment resolution. I will start with the proposed USERRA policy resolution. Next slide, please. This slide is included in the presentation, so you will have it available as you consider the USERRA policy. Next slide, please. Proposed resolution PEB 2022-01, employees returning to work from active duty. When an employee who is called to active duty in the uniformed services under USERRA loses eligibility for the employer contribution toward PEB benefits, they regain eligibility for the employer contribution toward PEB benefits the day they return from active duty. Health plan coverage will begin the first day of the month in which they return from active duty. Currently, employees regain eligibility when they have at least 8 hours of pay status in a month. Under USERRA, we need to restore benefits as of the day the employee returns. Only the board can extend eligibility greater than what the federal regulation requires of us. So we are asking the board to treat those that are returning from USERRA, including those with less than 8 hours of pay status in the month in which they return, the same as employees who regain benefits based on 8 hours of pay status. Our recommendation is to have it start the first of the month in which they return, because our longstanding practice in the PEB program has been full months of coverage. In reading this resolution to you today, it has come to our attention that it is written specific to health plan benefits. In the following example, you will see that it should have been written for all PEB benefits to start at the beginning of the month for an employee returning from active service. I will present the following examples to you, keeping in mind that the language in the proposed resolution will change to say employer paid PEB benefits when we bring this back to you for action. Next slide, please. Proposed resolution PEB 2022-01, example 1. Darren works at the Department of Fish and Wildlife. He returned to his job on Wednesday, August 17th, after 6 months of active duty. When Darren went on active duty, he was eligible for the employer contribution toward PEB benefits. When our employer paid coverage is reinstated, employer paid coverages are reinstated August 1st. This example shows how the eligibility will work for employees who return with 8 hours of pay status. The next example will show how the proposed policy resolution will also refine the current eligibility for employees who return from active duty with less than 8 hours in the month. Proposed resolution PEB 2022-01, example number 2. Jenny works half-time, 4 hours a day, at the Secretary of State. She returned to her job on Friday, April 29th, after 18 months of active duty. When Jenny went on active duty, she was eligible for the employer contribution toward PEB benefits. When do employer paid coverages begin? Employer paid coverages begin April 1st. Even though Jenny did not have 8 hours of pay status in April, her employer paid benefits will still begin April 1st because the USERRA protection requires coverage to begin the day she returns to work. Now, we are not aware that a scenario like this has ever happened in the PEB program, but we do want to have it in place under a rare circumstance that it does occur. We specifically put this example in here and wrote the resolution this way, so the PEB board will be aware that even if the employee worked less than 8 hours in a month, we would still have to put the benefits back in place when they return from active duty. There was a question related to the SEB program about when benefits began when a school employee returned from active duty, which led us to examine this requirement in both programs. So that is how this came to our attention.
Comments again, I just want to thank the crew for making this so explicit. I think given the times we're in and where we've been, that we have so many here in Washington that are being called up and or are in this predicament, certainly during the pandemic. And I just thank you guys for being proactive and being so veterans supportive. And I know it's not just veterans active duty, I might be using the terminology. I would also ask this team to make sure that our VERD group, we have a special Veterans Employee Resource Group, is aware of this, because this is just so sensitive about our alignment and support for our military partners. What a great way to show our support.
And this is Dave. I want to add one more piece of context for the board. The challenge here is that we realize that the current practice that we have doesn't technically fit the requirements of federal law. By prospectively enrolling the person who's returned from active military duty the first of the next month, anybody who comes back from active military mid-month is, by definition, not being enrolled the day they return. Because in our systems, our medical effective dates are effectively limited to 12 times in the year, the first of each month, the choices are prospective enrollment like we have, which doesn't really meet federal requirements, or retroactive enrollment. Now, normally, if there's a federal compliance issue, the agency will make a change because we're charged with ensuring federal compliance. The reason we need to bring this to the board is the retro to the first of the month is actually a slight expansion of eligibility requirements, which is the board's prerogative. But the whole reason I bring this up is I know that there will be other stakeholders with other populations who may be interested in retroactive enrollment. And the reason this one is here is because of the federal compliance issue. So if you have something similarly that you see that's rooted in a federal compliance, we'll certainly look at it. But I didn't want folks who might be listening to think that the reason this is are few options to comply with federal requirements in this instance. So that's why it's here. It's technically a slight expansion of eligibility, but it's rooted in ensuring federal compliance.
And I hope the board applauds this proactive leadership of doing the right thing and kind of warding off these issues. Any other comments or concerns from the board? Molly, carry on.
Thank you. Next slide, please. Now I will move on to the proposed dual enrollment policy resolution. Next slide, please. Last year, we asked you to pass 8 resolutions in order to implement the requirement that an individual be limited to a single enrollment in medical, dental, and vision plans in either PEB board or SEB board benefits as set forth by Senate Bill 5322. This slide and the next slide are included in the presentation, so you will have them available as you consider the dual enrollment policy. Next slide, please. The new resolution was written using the same language as the dual enrollment resolutions that were passed last year. I'll just give you a brief refresher on what those were. So when we say employee, we mean all employees of state agencies, higher education institutions, employer groups, tribal governments, and other entities described in RCW 41050116A. When we say school employee, we mean all employees of school districts and charter schools, represented employees of educational service districts, and beginning on January 1st, 2024, all employees of educational service districts. When we say PEB benefits, we mean one or more insurance coverages or other employee benefits administered by the PEB program within the healthcare authority. And when talking about an employee or a school employee, it means any employee eligible for the employer contribution toward PEB benefits or SEB benefits, respectively, unless stated otherwise. Next slide, please. I'm also going to just take a brief moment to give you a refresher on what happened last year. So during open enrollment in fall of 2021, for plan year 2022, employees who were currently dual enrolled could choose either the PEB program or the SEB program for their medical, dental, and vision plans for themselves and for all of their covered dependents. Next slide, please. What can employees do to avoid dual enrollment? So this is our current ongoing process right now. Beginning January 1st, 2022, employees who become newly eligible for the employer contribution toward PEB benefits or who experience a special open enrollment and who are already enrolled in a SEB health plan can either enroll in a PEB health plan or waive their enrollment in a PEB health plan. They must make their decision within 31 days of gaining or regaining eligibility or within 60 days when there is a special open enrollment. Next slide, please. All that being said, I will now introduce the proposed resolution. Proposed resolution PEB 2022-02 employees may waive enrollment in dental. An employee who is eligible for the employer contribution toward PEB benefits and who waives enrollment in a PEB medical plan when they are enrolled in TRICARE, Medicare, or other employer-based group medical and are not enrolled in SEB medical may waive their PEB dental only if they are enrolled in both a SEB dental plan and SEB vision plan as a SEB eligible dependent. This resolution is to enable employees to waive PEB dental as described in the resolution. Although the PEB board cannot make policy on behalf of the SEB board, it can set the requirements for waiving PEB medical and PEB dental. This resolution is intended to resolve the issue of an employee who waives PEB medical for a reason other than to enroll in SEB medical, but is eligible for SEB dental and SEB vision as the dependent of a school employee and would therefore need to be able to waive PEB dental in order to enroll in SEB dental and SEB vision and not have a dual enrollment conflict. We are recommending this proposal because current policy does not allow an employee to waive PEB dental for any reason other than when waiving PEB medical to enroll in SEB medical, SEB dental, and SEB vision. The scenario in the following example reflects an issue that was identified during implementation. Next slide, please. PEB Resolution 2022-02, example number 1. Jeanette is a custodian at the University of Washington and is enrolled only in PEB dental. She waived PEB medical because she is enrolled in TRICARE. Jeanette is married to Taylor, who is a teacher at Roosevelt Middle School. Taylor enrolled Jeanette in SEB dental and SEB vision during annual open enrollment in 2022. Can Jeanette waive her PEB dental? Yes, this resolution would enable Jeanette to waive her PEB dental without having to enroll in SEB medical. But in order to do so, she must be enrolled in both SEB dental and SEB vision as a SEB eligible dependent. Before I move on to the next steps, are there any questions? I don't think I'm hearing any questions. So next slide, please. Thank you. The next steps are to incorporate board feedback in the proposed policies. The feedback needs to be submitted by March 25th, 2022. Then we will bring the recommended proposed policy resolutions to the board for action at the April 14th, 2022 board meeting. Next slide. Unless there are any additional questions, I will consider my presentation done. Thank you very much, everybody.
And Emily, thank you. I am not seeing, so thank you to both of you.
Thank you, Chair Birch.
We're running a little behind. Would the board like to take a 5-minute stretch break, or do you want to plow through and cover the last 2 agenda items? Three agenda items, I apologize.
I need a stretch break.
Okay, 5-minute stretch break, and we will resume at, well, it's almost 10:30. Why don't we resume at 10:35? Okay? Right back, everybody. Hey, everybody, welcome back from our quick little stretch break. I hope everybody did like something healthy, water, stretching, whatever. Do we have everybody besides ourselves? I always feel like some other ship. Okay. Got more there, that camera. All right, welcome back, everybody. We're going to move into our next agenda item, the UMP Pharmacy Benefit Management Update. Jenny Switzer is our Senior Account Manager for MODA. She's going to bring forward up to date on the changes implemented by MODA for UMP, and these went into effect this past January. And these materials are behind tab 6. And Jenny, welcome. Good to see you up there on Mount Rainier. We're going to all go get hot tea with that chilly background.
I know, I always feel like I should put a coat on when I have this background going. Good morning, Chair Birch and members of the board. As mentioned, my name is Jenny Switzer, and I'm a Senior MODA Account Manager for UMP. Today, I'm going to be giving an overview of the UMP Pharmacy Benefit Management contract implementation. So first, I want to provide a little bit of a background to refresh everybody's memories. So the Northwest Prescription Drug Consortium, known as the Consortium, is jointly administered through the Washington Prescription Drug Program and the Oregon Prescription Drug Program. Both states joined together in 2006 to increase our purchasing power. Programs participate in the consortium to purchase or reimburse drugs. And per RCW 7014-060, UMP must use the consortium for its pharmacy benefit. The prior MODA Health contract to administer the consortium expired on December 31st, 2021. A competitive procurement was completed and MODA was awarded a new contract. The new contract became effective 1/1/2022, and it's a 5-year contract with an option to extend the contract in 1-year increments up to a total of 5 years. On the next slide, you can see a really quick overview of MODA's structure. MODA administers most aspects of UMP's prescription drug benefit in-house. That's those blue triangles you see there. And they subcontract with another pharmacy benefit manager to carry out some behind-the-scenes functions. On the next slide, I'll go into more detail on what these functions are. So MODA and Novitas roles, the subcontracted PBM with the previous contractor was MedImpact. With this new contract, the subcontracted PBM is Novitas. So MODA, as you can see with the blue here, they provide account support, member services, clinical services, reporting and analytics, and benefit design. Novitas provides claims processing, pharmacy network management. They have an additional reporting portal, and they administer our rebates for UMP. So on the next slide, I outlined some of the benefits of Novitas over MedImpact. With Novitas, we have more clinical programs to support the health of our members, such as the pharmacoadherence programs. Costco mail order can be added as a second mail order option, and we're considering that for benefit year 2023 right now. This would be in addition to Postal Prescription Services, who has been our mail order pharmacy option with the previous contract and is currently in the new contract. I just wanted to note as well that UMP is working with Costco through MODA to provide over-the-counter COVID test kits. And so that's a great opportunity for us to work with them on a smaller scale as we consider the potential implementation of adding them to our mail order benefit for next year. With Novitas, we're given greater options for administrative budget flexibility as they offer the option of paying on a per claims basis or on a per member per month basis. With MedImpact, HCA was allowed up to 4 user accounts on their reporting platform. And with Novitas, we have up to 30 user accounts that we can access. This allows for more options for HCA staff to complete data analytics and create custom reporting. And then finally on this slide, Walgreens was out of network with Med Impact and was added to UMP's network with the addition of Novitas as the subcontracted PBM. So here we can see some member experience impacts. What stayed the same, the benefit design, prior authorization processes, customer service, complaints and appeals process. We maintain the large pharmacy network of about 53,000 network locations. Arden Health for specialty pharmacy continues to maintain that role. And as I stated before, Postal Prescription Services is our mail order pharmacy. So what changed with this new implementation was there were new group ID and BIN numbers provided, which are the numbers used by pharmacies for claims processing. All UMP members did receive new ID cards with this updated information, with communications on the need to use those new ID numbers beginning in 2022. The pharmacy website is more user-friendly and provides more clear access to price check tools, pharmacy locator, and claims history. As claims are processed by Novitas, there is a new address to submit out-of-network claims to, and we've provided a lot of communications and updated COCs and other associated communications so that members are aware of that. Novitas uses Metaspan for drug designation and Med Impact used for Data Bank. This change in drug databases resulted in some changes in generic and brand drug designations. Based upon January's data, this has resulted in a slight improvement in costs for UMP members affected by that drug designation change. And then with Novitas, CVS is out of network. However, Walgreens is in network with Novitas, which used to be out of network. And so members did have some impacts based on network availability. In the next slides, we'll go over that a little bit more in depth. So here we can see net changes to pharmacies, network pharmacies by county. With the change to Novitas, as I mentioned, CVS left the network and Walgreens joined. This did represent a net loss of 47 CVS locations, but had offered us an additional 133 Walgreens locations. As you can see here, this resulted in a net gain of pharmacies in each county affected, with a total increase of 86 additional network pharmacies. On the next slide, we'll go into more depth at the zip code level of the effect of these changes. Here, yes.
Go on. What sort of notification are we or did we provide to folks that might have been habitual about using CVS to switch over to Walgreens? How is that handled, and are we getting it?
We did provide a lot of communications. If we can hold for just one more slide, I go into quite a bit of detail about the communications that we provided to members.
Okay, thank you.
Yeah. So here you see network pharmacy changes by zip code. The green areas on the map indicate zip codes that had a net increase in network pharmacies due to Walgreens joining our network. The red zip codes indicate zip codes that saw a net reduction in network pharmacies, and the gray areas that are not covered were not affected by the change in CVS and Walgreens network changes, as they didn't have those pharmacies in those zip codes. So then on to the question about communications. We very heavily lean towards too much communications is better than not enough. And you can see here, we provided the pharmacy open enrollment brochure to all members. The What's Changing publication went to all subscribers. The PEB UMP open enrollment video, which was pre-recorded and available to members on demand, was put on the HCA website and sent out to members. The 4-year benefit newsletters went out to all PEB program subscribers. The UMP newsletter also went to subscribers. And we also had the UMP webinar, which was pre-recorded and available on demand to all members. The WSRXS welcome postcards and quick start guides went out to members and subscribers, as did welcome letters. And on the regents.com website, we had a web alert for members notifying them of the change, and very specifically about the change in pharmacy ID numbers. On the next slide, there's some additional communications that we provided. MODA and HCA included additional communications to members through multiple different avenues. Additional communications to members were provided through the COCs. HCA worked with MODA to develop customized letters to members impacted by changes. So here we get to the question on how did we notify members about network changes? In addition to all of these other areas, the almost 14,000 letters were provided to PEB members who filled prescriptions at pharmacies that left the network. And those letters did include the 3 closest network pharmacies to their home address. And then over 151,000 letters were sent to PEB subscribers notifying them of the change in pharmacy ID numbers and letting them know to use their new ID numbers beginning in 2022. HCA and MODA also developed a custom customer service recorded greeting that played to callers when they called MODA before speaking to a customer service representative. The December recording informed callers that they would be receiving a new ID card and to use it in 2022. And the January greeting notified callers that they should have received a new ID card in December and to use that currently in 2022 when filling prescriptions. In addition to that, when members did connect with MODA customer service, MODA customer service staff were trained on all of these changes and were given a pretty heavy training on the changes to network pharmacies so that when members called, if that member was indicated as someone that was in an affected zip code, they were provided additional information on that as well. Additionally, HCA developed a custom Smart Health activity for UMP members, notifying them of the change of in pharmacies, and 858 PEB members did participate in that activity. And then Chair Birch, I just wanted to check back. Does that address your questions?
Yes, and I see that Elliot has her hand raised. Elliot, go ahead with your question for Jenny.
Yes, what's an activity tile?
Activity tile, so the Smart Health Wellness virtual platform has activities that members can complete to earn points or to be notified of changes. And so a custom activity is really, we call them tiles, but it's just a custom activity where we at HCA create the content and post that to Smart Health and target it towards specific members. So this activity tile was targeted towards PEB UMP members, notifying them of the change.
Elliot, we often use our wellness platform and create these types of activity communication opportunities. When we rebooted the life insurance benefit, we had a life insurance calculator. When we did LTD, we had something that describes the enrollment process for LTD and what medical underwriting is. We have a tile that's specific to the Centers of Excellence hip and knee replacement to learn more about that. So we often use our wellness platform as another communication tool for people who are actively using the Smart Health platform.
Thank you.
Okay, thank you for those questions. And so this next slide is implementation related member impacts that I wanted to discuss with you. To date, there have been 0 appeals related to implementation activities. This is due to MODA closely watching claims and addressing issues as they're processed. And MODA did create 9 new customer service positions and provided that additional training that I had talked about to the staff. And those 9 customer service positions are going to remain post-implementation as well. MODA staff also worked through the holidays and worked into overtime, so members had access to customer service when they needed it. And so the issues were addressed as soon as they became aware of those issues. Some member concerns that MODA received include member inquiries on differences, including some changes to concurrent drug utilization review edits The implementation activities caused some claims to deny for high dose when they had previously been approved. MODA handled those issues as they were received and manually processed those to ensure members had access to the drugs that they needed. They entered overrides to allow those claims to process and have updated the DUR edit to return a message to the pharmacy rather than having the claim place a hard stop on that so members could get their drugs. Another noted issue was with compound claim partial rejections for non-formulary ingredients. When these partial rejections were received at MODA, they reviewed previous claims data, and just like with the last one, they would enter an override if the ingredient was previously approved as part of the compound adjudication. MODA did receive a small amount of pricing complaints. Many are regular changes that take place on a regular basis or annual basis and are outside HCA or MODA's control. Price changes in 2022 indicate cost savings for some members and prescription cost increases for others. Price changes were a result of drug source classifications, maximum allowable cost list changes, and changes to network pharmacy guarantees as contracted with those pharmacies.
Do we have a summary of what that net financial impact is? Sounds like.
Well, yeah, I had MODA pull some of that data, and it is showing that overall it's a cost savings. Overall, like I said, some people are going to see a little bit higher price on their prescriptions where maybe they were paying 58 cents before and now they're paying $1.58. But overall, for the group, we're seeing right around a 4% improvement in costs for our members that were affected by this. But MODA is tracking that very closely so that they can report out to us if we start to see some big variations in those numbers.
Getting that 4% reduction is what I was looking for. That's great information, and really it sounds like for such a significant modernization and increase in the volume of distribution sites, pharmacies, it sounds like this has gone rather smoothly. So kudos to the pharmacy team and you too.
It did go extremely smoothly. I didn't want to jinx it before implementation was over, but now I can say it was a very positive experience.
Great, and I think Tom has his hand up. Tom, you're muted.
There we go. Oop. Am I unmuted now?
You're good.
Good.
Okay. So first, I was wondering, it was my understanding that CVS was purchased by Rite Aid, or I'm sorry, CVS purchased Rite Aid. Is that correct?
I would need to go back and check on that. I'm not sure on that one.
And then because there are a lot of Rite Aids. Are they, if that is true and Rite Aid has been purchased by CVS, will that mean that Rite Aid would no longer be involved with us as well?
Well, that change didn't take place for 2022, but like I said, I can check back with MODA on that to see if they have information on that. They do have to notify us 180 days prior to leaving the network. And so we haven't heard anything currently on that, but
I can shed some light on that. Rite Aid acquired Bartell's and CVS acquired Rite Aid, but they didn't acquire the stores in Washington State for some reason.
Yeah, thank you for that clarification, John. We can, market consolidation and changes might be something that this board needs to have periodically, so changes. So we can do a little more exploring, Tom, and bring that back.
And then, go ahead. Sorry.
The point there was Rite Aid customer involvement in Washington. Go ahead, John. I think you were trying to jump back in. No.
Yeah. So let's say that I have a generic drug that I have been taking, and I've been getting my prescription filled at CVS. Now I could switch to Walgreens, or I could go to some others. Am I going to be paying the same price at Walgreens as I would be at Fred Meyer or blanking, other pharmacies that are in our network? Am I going to be paying the same price at Walgreens that I would be for that same drug, or am I going to see differences in pricing?
You could see differences in pricing. Each network pharmacy has a financial guarantee or a contracted amount that they've entered into with Novitas on MODA's behalf. There are maximum allowable costs. So that's a cost limit that's put in place for generic and brand drugs. So it's not, you shouldn't see a huge jump, but there could be, you could save money, or you may end up paying a few cents more. MODA has a price check tool on their website where you can compare any pharmacies to see what your price for different drugs is going to be. Also, when members contact MODA, which was indicated on those letters that we sent out, that they could contact MODA to get more information on available pharmacies for their specific drugs. MODA uses a price checker for local pharmacies and lets members know where they can go to get that prescription for a comparable cost.
Okay, thank you.
And I remind you and other board members, the overlay with cost containment efforts in this area is the value-based pharmacy option that we voted in. Dave, I got the language wrong.
The value formulary.
Value formulary. That puts downward pressure. That says to MODA and Novitas, you've given them directions of you go find us the best, pricing, cost containment. But whether things shifted 12 cents up or down depends on your drug. Second thing I want to just comment about, David's been very involved at the national level with the Purchasers Business Group on Health. And if you listen to the President's State of the Union speech, he is committing, and there is significant movement that Dave has been participating in pushing more downward cost containment efforts on Medicare pricing, which will move the whole market down. So there's, for the first time ever, kind of a commitment to keep moving pricing down. And these are significant things that HCA and this board have been doing to lean in on cost containment efforts, particularly in the pharmacy realm. So
I'm sorry to interrupt one more time, but since it's consistent, I'm wondering, Dave, didn't I hear a year or two ago when Ryan was doing a presentation that Walgreens specifically had refused to join because they believed that since they were a corner drugstore, I think was the term I heard, that they didn't need to follow these cost containment efforts?
I can speak to that one, Dave, if you want. Yes, Walgreens was very hard to get in network. Their costs, they weren't willing to sign the financial guarantees, the contracts for the rates that we were requiring. Their rates were well above what we thought was appropriate for our members. And so that's why it was such a big win when Novitas was able to get them to reduce their costs down and enter into a contract with them to provide drugs at the rates that are appropriate based on our considerations for members.
Okay, thank you.
Mrs. Elliott, it was Walgreens that acquired Rite Aid.
We will definitely bring back some insights about the relationship between CVS, Walgreens, Rite Aid, and Bartell in the Pacific Northwest.
But it's likely to change like on a quarterly basis is what's happening in the industry. But we will attempt, that's a very interesting thing to think about, is how market consolidations and all this movement. Okay, Jenny, thank you. I am not seeing any other questions from board members. And again, Dave and Jenny, we really appreciate all of this pressure on cost containment, best deals for our members, and I continue to really strive towards customer.
Thank you.
So with that, we are going to move on to our next agenda item. This is regarding the 2024 Uniform Dental Plan Benefit Design Introduction. Ellen Wolfhagen is our Senior Account Manager in the Urban Division. She's going to share some foundational information for our Uniform Dental Plan Benefit Design discussions that could lead to changes for 2024. Her materials are behind tab 7. Welcome, Ellen.
Thank you, Chair Birch. Good morning. Good morning, members of the board. Again, my name is Ellen Wolfhagen. Among the benefits that I manage are the dental benefits, and today I'm going to talk about potential design changes for 2024 for the Uniform Dental Plan, which we also call UDP. I'm going to give you a bit of background, talk about timelines, talk about the proposed options. I'll give you some general context for them, and then some specific information, and there'll be time for questions. So in terms of the background, there have been no significant changes in benefits by PEB for 20 years. And 80% of PEB program members, those are active members, use UDP. 93% of our self-pay population, that includes retirees, people on leave without pay, and COBRA coverage, 93% of those people use UDP. And as you recall, SEB fully leveraged the PEB benefits, so the program benefits are the same for both PEB and SEB. Next slide, please. In terms of the timeline for the board, today we are doing an introduction of the options. Next month, I will bring back information on utilization and potential cost ranges, so that we'll talk about costs in terms of small, medium, and large impacts. And by May, we hope to reach consensus on relative priorities. And the reason that we're looking at relative priorities is in case we cannot get everything fully funded, it will provide information for OFM and the legislature. Next slide, please. The remaining benefit design cycle means that in the summer, HCA will work on an introduction of the budget decision package that's needed. In September, we hope that the budget proposals are finalized by the governor. In the spring of 2023, the biennial budget for fiscal years 2023 and through 2025 will be finalized. So the earliest that the benefit changes could be introduced would be January 1, 2024. But if supplemental budget is necessary, then it would be January 1, 2025. Next slide, please. I'd like to just briefly go over the current UDP plan design. So first, I'd like to say this is a preferred provider organization plan, so a PPO plan. There are different types of providers. The preferred providers have the best contracted rate and therefore the most coverage. Premier providers are also contracted, but it's at a higher rate. So it's a higher cost to the plan and also to members. And that may be reflected in lower coverage percentages. The deductible for UDP is $50 per person, up to a maximum of $150 for a family. Class 1, which is preventive services, such as cleanings, x-rays, things like that, are covered at 100%, but they do count towards the annual maximum. Class 2, which is generally fillings, are covered at 80%. Class 3, which is more major work, crowns, bridges, etc., are covered at 50%. TMJ, which is something that we will talk about in more detail later, is covered at 70% with a $500 lifetime limit. The annual plan payment the max that the plan would pay is $1,750. And again, this is very different from the medical plans, because when we talk about the maximum, it's the maximum the plan would pay, not the member out of pocket. Dave, would you like to set up some discussion about the context for market comparisons?
Yeah, as Ellen goes through some of the potential benefit design changes that could be on the table, you're going to see some benchmarking with the book of business, and then also on every slide you're going to see the WEA, the Washington Education Association, and its pre-SEB portfolio. And I wanted to give context as to why that's one of our benchmarks here. You know, it's no secret we have a SEB program now, a separate sister program to the PEB program, and one of the areas that has had the most questions or advocacy or an interest in looking at the benefit offerings has been from school employees around the dental benefit design. The WEA trust benefit, which was used by many, but not all school districts prior to SEB, had a very different structural model compared to what the uniform dental plan is. And so because many of the conversations and advocacy has come specifically from school employees of the WEA, and we're having the same presentation and conversations with the SEB board, we wanted to do the benchmarking because it's certainly relevant and asked for by the SEB board. We wanted to give the same information to the PEB program. So, you know, for years, the SEB program slides saw PEB, and so now you're starting to see some SEB appearances more in the PEB slides, and just wanted to give that context as to why. Because ultimately, when a decision package is put forward and anything, if it's picked up and funded by the governor's office and legislature, would move both programs in the same direction. Just it's important context for SEB, and so we thought it would be important context for PEB as well. So before I turn it back over to Ellen, I see Elliot has a question, and it might relate to what I just said. Elliot?
It relates to the Delta Book of Business. What is that?
Oh, well, we'll let Ellen go with that.
So if we can go to the next slide, I'll explain that. Thank you, Elliot, for the question.
Before you explain, I think Sue wants to add a comment, and then you'll explain that along with moving along.
I
Okay.
think because of our commitment about equity, I also think we need to see a column about Medicaid. I think what it will portray is the vast generosity of all these plans compared to Medicaid, and we are trying to help the public and the legislature understand that if we want a healthy society, we need to level things out. I'm not suggesting we bring our benefit design down, but I think our dental benefit design down, but I think it's a very important way for us to showcase what is going on in society and how we need to aspire to have more equity. So if you would not mind in the future, Ellen and Dave, I think that would be a smart move.
Thank you, Chair Birch. I've made a note of that. So to explain the market comparison and to address Elliot's question, the Delta Book of Business here is major employers. So it would include companies like Amazon or Boeing or Alaska Airlines. These are preferred provider organization, PPO plans only. There's no managed care comparison in here. That's the setting for the Delta Book of Business. The WEA plan, as Dave mentioned, is pre-SEB. So as you can see, there are some changes across the different columns. And I want to make note of a couple of things. Class 2 also includes periodontic care, oral surgery, and that dreaded process of root canal. Class 3 includes crowns of porcelain or composite or gold. So this is just a comparison generally across the board. Next slide, please.
Ellen, before you move on, Tom has a question, please.
Yes, I was just wondering if the SEB, because this WEA plan that you're showing is a pre-SEB, do the current dental SEB plans mirror the PEB plans?
Yes, they're exactly the same. So that was when SEB was created, we leveraged the PEB plan, so the benefits are exactly the same.
All right, thank you.
Mhm. Next slide, please. So the options that I'd like to introduce today, and please make note, these are not in priority order. These are the kinds of differences that are very common when we look at benefits across different groups. So we're really keying in on the major differentials in benefit design. So one is creating an incentive for preventive services, and I'll explain more about how this works in a minute. Another is allowing composite materials for fillings to be reimbursed at the same rate as amalgam fillings. And again, I'll go into more detail on this in a minute. Perhaps raising the annual plan maximum. Just a reminder, in dental benefits, it's the amount that the plan pays that is set as the max, not an out-of-pocket max. We're going to look at perhaps removing a deductible for children's benefits, and then we'll look at TMJ lifetime benefit and perhaps some changes there. Next slide, please. So working on the preventive services and providing an incentive, again, preventive services are things like cleanings, x-rays, perio maintenance, fluoride treatments. What we are looking at is increasing the plan percentage coverage for class 2 and class 3 based on having a preventive visit the year prior. Having a preventive visit will increase the standard increment up to a maximum, and then benefits could be decreased for non-use to an established floor. Next slide, please. Large employers currently are not using this, but there is interest, and one of the alternative ways of doing something similar is changing plan maximums. So just consider that in the back as well. Pre-SEB, WEA had a plan that started at 70% for class 1 and class 2, increased by 10% up to 100% plan coverage. I just want to make a note that under UDP in both PEB and SEB, class 1 services are covered currently at 100%. Next slide, please. For those of us who are visual, this is just a visual explanation of how it works. You have the current level, you use your benefits, your benefit coverage level goes up by 10%. You use your benefits the next year, it goes up by 10%. So this is just another way to present the information. Next slide, please. Amalgam versus composite. So amalgam, as some of you may know, is the essential metal that's used. It does contain elemental mercury, and it is less commonly used than it had been in the past. So for front teeth, composite is covered the same way that amalgam is covered, but for posterior teeth, molars, there is a differential in how UDP covers this. Composite is covered as an elective and is not provided the basic coverage for class 2 fillings. Composite materials provide good durability and resistance to fracture, and they may also be more aesthetically pleasing because they can be matched to the tooth color. And what we are proposing here, looking at, is covering composite materials at the same coverage level, so percentage that the plan would pay, as amalgam materials. Next slide, please. So again, under UDP, composite materials are currently considered elective. And among large employers, it's very interesting that they're not included, composite materials are not included in self-insured plans. Remember, UDP is a self-insured plan, but they are included in smaller, fully insured groups. And WEA did cover posterior composite fillings the same way that they covered class 2 benefits. Next slide, please.
So Ellen, as you move on from this one, I do want to highlight that part of this benefit idea being on the table, this particular lever, was that equity lens that we talk about. I mean, we're essentially saying, the current generally pervasive dental insurance practices, if you can afford to have white teeth, then you can have white teeth. Otherwise, we'll cover your mercury filling level. And it just has when you boil it down to that kind of simple statement, that your socioeconomic status can determine the color of your teeth if you have filling based on what your filling needs are. It squarely put this one as something that needed to be discussed as a potential opportunity. And I just don't want to miss the opportunity to highlight that aspect of this particular benefit design lever. It really, that all important equity lens rears its head right here. Here's a specific example of benefit design.
Thank you, Dave.
Absolutely. Spot on.
I'm sorry, Chair Birch, I could not hear you.
I just said, I thank Dave for pointing that out because he's spot on. It's a perfect example of kind of this really trying to drive towards health and well-being for people.
Go ahead, Ellen.
Okay. Plan maximum. So again, this is the amount that the plan pays. The current level is $1,750 and has been since 2008. And if you're curious, the comparison is that would be the same as $2,285 currently. By the same token, deductible level has been kept at $50 per person, and under the current economics, that would be the same as $65. Preventive services count towards the plan maximum, but even though they're covered at 100%, meaning that there's no cost share for those benefits, but it does count towards the maximum. On average, people use 2 preventive visits a year, and average PEB members pay between $325 and $350 for those 2 visits. That's not each, that's combined for the 2 visits. Next slide, please. So again, looking across the different plans, you will notice that there are differences. Book of Business has about 43% of them have a $2,000 maximum. WEA did have a $2,000 maximum. We talked about PPO, Premier, and out-of-network providers. One way of dealing with that difference is changing the percentage of coverage. Another way of dealing with it is changing the plan maximum, which is what the pre-PEB WEA plan did. So you had a lower plan maximum that could be used for the higher paid dentists, if you will. Next slide. So again, looking at deductibles across the market, WEA plan had no deductible at all. We have a deductible for class 2 and class 3, $50 individual up to $150 family, which is the same as the industry standard, and no deductible for preventive services. The Book of Business calls it waived for preventive services. The effect is the same. Next slide, please. So as we consider waiving the deductible for children, the benefit would be reducing the financial barriers for pediatric care and encouraging early preventive visits. What we know is the earlier that children get dental care, the more long-term health benefits there are generally, as well as developing lifetime habits of good oral care. And waiving the deductible is something that we would consider applying to restorative care, which is class 2 or class 3 as needed. One of the factors that can be looked at is the age limit of how we define children. Next slide, please. WEA had a design called Healthy Start, which is a different approach to children's dental health. And that covered children up to age 15. So again, as I said, we could consider different age limits. We could consider up to age 15, up to age 14, up to age 16, and what those impacts might be. And I'll have information next month for you on that. Under the Uniform Dental Plan, children's coverage is the same as adults. There's no difference in the amount that's covered. There's no difference in the percentages. And there's a $50 deductible. And class 2 benefits, remember that's generally fillings, is covered at 80%. Under Healthy Start, it was covered at 100%. And we have a plan maximum that applies to each person in the plan. And again, it's $1,750. The Healthy Start program didn't have a plan maximum for those specific children benefits. It's also important to note that the Healthy Start plan didn't mesh, I guess, with the incentive plan. So there was no increase because Healthy Start covered everything at 100% right off the bat. Next slide, please. So in terms of the temporomandibular joint, TMJ benefits, this is the joint at the back of your jaw. It's clinically treated for disorders that result in pain or a lack of range of motion or teeth not meshing properly, et cetera. Surgical benefits, which is sometimes the prescribed course of treatment, are covered medically. It requires pre-authorization. Those are covered under our medical plans. And that's not something covered here. Next slide, please. It's interesting to note in this that Uniform Dental Plan has always covered TMJ at a higher percentage than either the Book of Business or the WEA plan. However, the maximums are very different. So UDP has a $500 lifetime maximum. The Book of Business has a 50% coverage limit with a $1,000 annual maximum and a $5,000 lifetime. But please note that on the big employers, Boeing and Alaska Airlines have no coverage at all for TMJ. And the pre-PEB WEA plan was very similar, 50% coverage, $1,000 annual max, $5,000 lifetime max. Next slide, please. So what are we talking about in terms of coverage? It's generally spacers or retainers. And again, it doesn't cover anything in surgery, and we currently cover a higher percentage than most employers. Next slide. Thank you. So at the April meeting, I'll be providing some data on utilization of these different, what Dave calls levers that can be adjusted for different benefits. We'll look at potential cost impacts in terms of a small, medium, or large range, and I'll provide any additional information that's requested. And now I'm open to questions.
Thank you, Ellen. Really thorough presentation. I believe Scott has the first question. Scott, over to you.
Thank you, Chair Birch. Hopefully you can see me. try to turn on my camera. But my question had to do, I appreciate Dave bringing up and always being conscious about equity. Certainly that is an initiative of the governor's office and something that we all need to be cognizant of as we're administering these plans. One thing that caught my eye was the pre-SEB WA plan of the incentive of 70%, 80%, 90%, or 100%. Every year of preventative care that you get a reduction in or increase in the amount of covered services. I'm a little concerned from an equity lens because there's no income threshold or connection to that. So that if you had to make a difficult choice of perhaps providing for your family and then not getting self-care for dental care, you're then put at a disadvantage early on to really catch that up. So that's one. And then of course I'm putting on my HR hat of it does make our benefits look a little less attractive early on for people compared to maybe 100% of preventative services being covered. So that, you know, if you're trying to recruit and retain individuals early on, you have to stay on a certain time to achieve full or maximum benefit. So those are two items that I'm a little concerned with from this presentation, and would love to hear other thoughts on that. Thank you.
Those comments, but I do think this summer the governors and OFM are going to lead a pretty significant, caused by the Great Resignation, a pretty significant review of compensation and benefits. So it's something that I think will keep elevating. And I also want to, I lost my train of thought. Let me turn it over to first. Is it first? So Dave has a comment, and then we have both Elliot and Terry lined up, and then Elliot.
Yeah, I just want to be clear that when Ellen comes in April, there'll be very specific proposals. The goal today was just to kind of set the table, if you will, with some foundational information. I could already tell you that don't just look at the WEA incentive-based column and think that that's what's going to be proposed. There's definitely some differences from what are being looked at, but it was to describe some of the general concepts. So keep that in mind, Scott. But I didn't want people to incorrectly assume that the proposal, specifically with the incentive benefit design, was going to be proposing something that was in one of the other columns on the chart. We wanted to lay the foundation, show what kind of the market had been and currently is, and then there'll be a very specific proposal next month. So I just wanted to add that context. Then I think Harry was next.
Okay, if that's me, I thank you for the presentation. It was really superb. I want to echo what Scott said, totally, all of his comments, as well as there's a complexity associated with trying to manage an incentive or disincentive program, keeping track of it, booking it, and all those kinds of things. The second comment I like to make is of course, I agree with looking at all the different potential options, but I wonder if there's a possibility to, and maybe I missed it, but consider not including the preventive care visits into the annual maximum, similar to what we do typically in medical plans, where we encourage those things so we don't hold it against you or make you pay for it. I realize the preventive visits are covered 100%, but perhaps there's a way to fold some of that into the annual maximum by not counting it against the annual maximum. If that's not possible, then I guess I would encourage to look at the annual maximum coverage increase. Thanks.
Harriet, and I see Ellen taking notes and Dave too, so I'm sure they'll be coming back to us with all sorts of options. Next is Elliot, and then Tom, and I believe we have a question. So, Elliot, you're up.
Hey, the two preceding commenters from the board are right on about the preventive care measures being covered, because this also impacts senior members as well. I do know, just for the little part that I've been researching while PEB isn't in session, that seniors often can't afford dental care. And that's the thing they let lapse because of their need for medications and medical care, et cetera, et cetera. So I'm really grateful to my co-board members for bringing this up.
Elliot, thanks for that comment. And I'm going to help feed off that a little bit to Ellen. Ellen, there's quite a bit of public health work about seniors that have nutritional insufficiency because they don't have adequate dental care. And so then they fall and are hospitalized. So if you could dig deep into dental related kind of emergency room admissions. I know with kids, we also, I think there was some reports out a few years ago about it being dental pain being the #1 driver of them not going to school. So those things help us with our kind of disease impact and burden of disease and with the board's thinking. So again, as much of that as we can get into our line of thinking. And I really applaud staff and the board. We are coming into modern times where we're recognizing now more than ever that the mouth is part of the body and that we really need to try to equalize. We're seeing that movement with behavioral health. And so it's very exciting that everybody's willing to look at this and try to have that equity lens. You are next.
Yeah.
And then William Martin from the public, you're on deck for a quick question.
Yes, so I'm wondering, currently we offer 3 dental plans. 80%, I think, was the figure used that are in the uniform dental plan, but there are 20% are covered. And if I remember correctly, Delta Dental is another plan. And what's the third one?
So both Delta Dental and Willamette offer managed care plans. So we have Willamette is just called Willamette, and the managed care plan under Delta is called Delta Care.
Could we possibly have a comparison when we talk, when we do these comparisons, those two along with uniform dental when we come back?
We can certainly, Tom, but I just want to point out that because they're managed care, they're structured very differently. So there's a set copay. Under UDP. There are co-insurances, so it's a percentage. So yes, I can absolutely provide a comparison for you.
Okay, thank you.
And then I'm going to ask staff to open up the phone line for William Martin. I believe you have a question related to dental. If not, I'm going to push you into the public comment period. But if it's dental, go ahead and open up. I hear you.
It's not dental. It's not dental.
Let's finish out this issue, and we will recognize you in the queue for public comment. We'll be right back at you in a minute. Okay. Board members, are there any further questions for Ellen? Otherwise, I feel like she's given us a preview of what's to come, and we've given her some inkling of what we'd like to see. Ellen or Dave, do you need any further information, or board members?
Thank you so much for your time.
Great. And again, William, we have one more agenda. We're going to go back to our order of business, and then we'll be back at you in order of our public posting. So. Thank you for your patience. The last agenda item today, before we get to public comment, is John Parton bringing procurement and benefit planning cycles. John is our benefit and strategy design section manager. He's back with his presentation. I remind board members that we didn't have time for this at our annual retreat. John, we appreciate your patience and getting back to us. So he's going to share information on procurement and benefit planning cycles. John's materials are behind tab 8. Take it away, John.
Thank you, Chair Birch. Good to see everybody again. As you're all probably aware, we've already started the annual procurement and the benefit planning cycles, 2 separate pieces of work, but they're closely related. So today I'd like to give a brief overview of those 2 processes, where they're the same, similar, where they're different, and then do, as Dave mentioned earlier, a brief brainstorming session with all the board members, where there might be ideas for modifications to existing benefits or new benefit ideas that you'd want us to take a look at. So with that, we'll jump right in. Next slide, please. Goes over the annual procurement cycle. This one runs generally annually, and it takes 18 to 24 months to complete it. It's tied to the funding cycle and timelines. We started this one last year in the summer when the board approved the plan for 2022. So we started the new cycle then, and these effective dates are looking at plan year 2023. This is generally looking at two main bodies of work, looking at what payers in the industry are finding of value and use based on entire book of business review. So not just our members, but ours along with a myriad of other membership that they cover. And then also what, as was mentioned earlier, and we talked about this in detail with one of the updates, and there were questions, was around the procurement cycles, where we have existing procurement arrangements that need to be either performed or revisited. And so we're analyzing that work and executing on that work. So as you can see, or maybe not, depending on everyone's eyesight, mine is bad enough that I can't really read the details here, so I'll highlight it. The main components here, number one is identifying what new opportunities there are, and then evaluating those and assessing them, gauging the impacts, not just financial impacts, but the clinical impacts that they might have, as well as the impacts on attracting and retaining employees, as was mentioned in the previous set of questions, and how heavy the lifts are to put these into place. Those then move on for consideration in the funding review process. And then there's more work around implementation and actual execution once they're approved. So again, key takeaways, 18 to 24 months, currently looking at effective dates in 2023, and primarily based on procurement work and or what we're seeing in the payer segments as providing useful value. So with that, I'll move on. And again, we'll do a little bit of quick compare and contrast to the next slide and highlight the benefit planning cycle. So this one also 18 to 24 months in time, and it also is tied to the finance funding cycle and review. But this one is an additional 12 months into the future. So things we're looking at today for potential new benefits or major modifications would generally be for implementation in 2024. And then as you can see with the cycle, the boxes, the work we're actually doing, it's generating the new ideas where we like to start here generally with the board, given your knowledge and connection to the members that you represent. We want to hear your ideas. And we review those, develop those. They get advanced into proposals for consideration in the funding review. And then we bring those successful candidates back for further refinement here with the board and internally, and move on to implementation and execution as well. So the key takeaways for this, while I've said that the board is an integral part to both of these and we want to hear your ideas, we're also assessing what other large employer groups are doing, what we're seeing from the payer book of business review, and looking for real innovations that might have significant positive impacts for the residents in the state of Washington, even above and beyond what we'd be leading with for our own public employees, right, as a major cohort of members. So that's why we like to start with you all and hear your thoughts. So again, also 18 to 24 months in length, tied to the funding cycle and timelines for review, but an additional year out to 2024 and a little bit more strategic in the perspective of what we're looking for innovations. So I'll pause there for a moment. It's a lot of info trying to get us back on schedule a little bit, but any questions about either of those cycles?
I'm not seeing any hands. Thank you. I think it's rather clear, and your infographics are really quite effective and useful. So thank you for that.
Okay, then I'd just like to spend a little bit of the remaining time brainstorming. As many of you are aware, we did this last year. We generally do it every year, about what ideas you think we should be taking a look at what you'd like us to focus on during this current cycle. So I'll open it up to the board members. Anything you'd like to suggest?
And Dave, I'll kick us off because I'm not seeing any hands shoot up. But I think the new reality about hybrid work space might necessitate a little bit more kind of ergonomic in-home evaluation or just some adaptations in this space of hybrid work environment. So I would ask that you guys explore this area. I know there's some very interesting articles and work coming out, and I think we really have to consider that. This is likely to be a remote working, hybrid working is going to be a permanent impact, and how do our benefits need to change or be reshaped vis-a-vis that shift?
Yep,
one area of exploration for you to go searching to bring back to us any creative ideas.
Yeah, and just to clarify, yep.
Go ahead, John.
Just to clarify, Chair Birch, I assume you're thinking more holistically than just in-home evaluations, but also in-home care?
Yes, that's correct. I would like for you to explore that a little bit. I understand too that Amazon is doing quite a bit of adaptation of sending supplies to the home, getting rid of kind of more of the setting location and getting care delivery at the home. So I think there's some very interesting things going on in King County with Amazon using drones to deliver, for example, different infectious disease kits, having self-care, things aren't resolved in an hour, then a nurse practitioner or doc shows up at the front door. So I think we need to continue to explore, again, more of this shifting setting environment.
Thank you.
Connection at Amazon too.
Yep.
Who is there? So this is another thing I think we should be looking at. Other ideas or comments? Or Dave, I know I see your little wheel going off in your head. I invite you to in as well.
We have a list generated from a couple of places, so don't worry, there's plenty of work to do if there's nothing else brainstormed here.
Yeah, I actually think the only other area that I would comment about is just some of the enhanced behavioral health care that needs to occur given post-COVID, now given kind of all the kind of war tension. I just continue to be very worried about numbers on sentinel deaths and just coping skills and whatnot. So everything in the behavioral health realm, I hope you're coming back with some great new ideas and we can support our.
Yep, and recall too, just to remind the board, last year we had a couple of really good ideas that were generated from these discussions around behavioral health. One of those is advancing, and we're looking at implementation for that now. And we also have couple that were holdovers from last year, didn't quite make it through the process successfully, and one new one that's come up. So yeah, absolutely. And also looking at it through the lens of what impact that might have on rural access, as well as the equity lens of ensuring that everyone has similar opportunities and access that makes sense, right? And that's actually usable and valuable. Yep. Great call out.
I would also point out that the legislature directed a study on psilocybins, and so, those fantastic fungi and mushrooms and some of the alternative ketamine wrapped into some of your behavior.
Yep.
Our neighbors to the south are well in motion on this. I think we need to miss that to be looking.
Got it. Okay, well, as always, I thank the board for the opportunity to present. And if you have other ideas or things you think of after, don't hesitate to reach out to me directly. I'm happy to hear from you.
And yeah, board members, please remember that this doesn't have to wait for an annual event. Anytime you become something, just shoot on your Dave or John. All right. So I am moving into the call for public comment, and our time to take public comment, and we know that there is a first in line of William Martin. If there's anyone else on Zoom that would like to provide comment, please I see Alan Burke has already typed in his name. So I'll take these in the order that they've kind of signed in, and to effectively manage our time, I'd ask the commenters to please click on their open mic. We'll recognize you. Staff will open up one at a time. You'll open up your mic. You'll give us your name and who you represent, and then give the board in 3 minutes or less your public comment. So first is William Martin. Thank you, William, for being patient with us. Go ahead.
You're welcome. Thank you very much for hearing my comment. I'm a professor at Eastern Washington University. And the issue that I'm commenting on, it pertains to health equity, who is the custodian, obviously, of HSA funds for HSA eligible health insurance plans in the state. And for quite a while, I've been experiencing some significant issues with health equity that are just not being resolved. As of right now, I've been trying to transfer some assets from health equity to another HSA custodian, Fidelity, because health equity's fees for investing their HSAs are about literally 10 times higher altogether than what the fees are for me to hold these funds with Fidelity. And for at least 2, I think we're going on 3 weeks now, health equity has had all the documentation and will not make the transfer. And I've called to ask them about it, and they say, we don't know why, and we can't give you any ETA on what's happening. And frankly, that's just unacceptable for firms like this to be able to hold on to their clients' funds for weeks with them being in limbo and no knowledge of what's going on, what's the problem, or when it's going to be resolved, nothing. That's just unresolvable. So the 2 things that I would like to see happen for most, and this may be unrealistic, is for us to have some choice with regarding who our HSA custodian is, and not for us to be forced to go with one single provider who can then do whatever they want because they have a monopoly, basically. And if that's not possible, if nothing else, I would like to see this board put some pressure on health equity to say what you're doing here with holding people's funds and not transferring them in a fiduciary capacity within a reasonable amount of time is just unacceptable, and that the board won't stand for it. So if there are any questions, I will certainly respond, but that's basically my comment. So thank you.
Thank you very much for bringing this to our attention. I see Dave is writing furiously, and I'm certain he'll be following up with you for more specific information. So again, thank you. This is the very reason we open up for public comments and back on performance, and you have heard throughout this board meeting a real commitment to performance, so we will be following up with you.
Thank you.
Okay. Next in the queue is Alan Burke. Alan, we're opening up your
Hello.
line. So,
Yeah.
Alan.
Thank you. So Alan Burke, Executive Director of the Washington State School Retirees Association. We got about 7,300 members. I'm 5 years in the job here, and what I'm going to do in the next 3 minutes is try to do a little deeper dive into what you talked about earlier, and that is the uniform versus United Healthcare split on the Medicare self-pay part. And just to make sure you got the numbers right, according to the information Dave Eisenberger gave me, UMP has 38,964 Medicare retirees, and United Healthcare Complete. And I'm focusing on that one because that's the same basic coverages as the other ones. I'm not going to talk about United Health or the other ones, including Kaiser or Premera this time. But anyway, 38,964 compared to 2,607 with the same coverages. So really what you have is if you line 16 people up along a wall, 15 of them are going to choose uniform and one's going to choose UHC Complete. And that is in spite of the fact that uniform is literally $2,500 a year more expensive, or $5,000 more expensive for a couple. And I know we're into the second year of this and people haven't figured it out. And I really appreciate the Medicare Advantage option because that's saving a lot of money. But it is stunning to see that many people have chosen to spend additional money when they're older and frankly can't afford it. That's what I've been hearing from my clients here the last couple of months as well. What's going on? And my opinion from what I've picked up. One, retirees love Uniform Classic. That's what they've been doing for a while. There's a real lack of comfort for changing. They want to stay with the same thing. They prefer a government-run program to a private program. These are K-12ers and government employees that tend to line up a little bit that way as well. And they especially fear losing a major coverage. I've heard that a number of times when they have experiments with people getting $300K for a cancer thing totally paid by Uniform, and they're worried about switching back and forth as well too. But $2,500 a person, that's a little bit tough. So what's going on here? I think in many cases it's just people are in the dark about this, and I think what really has to happen is you got to do three things, which I'll talk about in a second. I'll kind of cut through this. First of all, I want to thank Ellen Wolfhagen. Spent a lot of time with our group in 2 webinars, plus she's going to present at our convention coming up in September. Dave Eisenminger has been very good to deal with as well. I don't have any problem with the staff and the information we have here as well. But what are we going to do down the road here? I think three things. One, we need more outreach. And the problem with the outreach is that you've got to deal with here a different clientele. These are older people. We have about half our people without email addresses. So whatever you do in terms of the technology, it's going to have to be cut down to the level of people that are frankly dealing with paper and pencil scenarios. Some are getting old. Some have lost a little bit of their acuity mentally, and they need some help. And frankly, I think help in filling out the paperwork is important, because a lot of people say to me that they just are scared about the paperwork, can't figure it out, are going to get messed up as well. By the way, all the people I've talked to, they've changed it to UHC, are happy with it. They have struggled with the process of getting there, but once they get there, things have been really, really good, for your information as well. I think you obviously you have to work at continuing to get the prescription drug prices down. I know you're doing that as well, but obviously the prescription drug prices are what's killing us on Uniform. And here's the one that probably is the big one to take away today. You're going to have to, in my opinion, realize the tripping point is going to get met. If we have finally people that are healthy decide to move away from Uniform Classic into United Healthcare, eventually you're going to have left people that are unhealthy. And then all of a sudden the costs are going to go, instead of $360 a month to $400, $500 or whatever. And then you're going to get a big, finally the tipping point will be reached, and Uniform Classic will have a tough time hanging in there. And ironic, you talked earlier today about doing more with Uniform and less contracting out. If the numbers keep going up and there's a good alternative with United Healthcare Complete, people are eventually going to switch. And then what are you going to do then, back and forth? I know you offer lots of things. I know that you can argue basically that there's all sorts of things here. But the fact of the matter is, if you line up 16 people and 15 of them choose Uniform Healthcare, or excuse me, you choose Uniform and are willing to pay $2,500 a person more, either we have a outreach program or we have something we have to do to make sure people are aware. I know you're aware of all this, but I wanted to pass on from my reactions from people that in our membership about the fact that this is a big deal, and eventually the cost of Uniform are going to push people out of that to other options. Thank you.
Those comments, Alan, I again see the staff taking copious notes, and I'm sure the board will be discussing this. I think Elliot might have a question for you. Or Elliot, go ahead.
Yes, I'm very involved with RPEC, and I do have my finger on the pulse of many state retirees. I agree with you, Alan, that as our population ages and as these premiums go up, you're going to have only the sickest people in UMP. The thing, and I've read copious articles now, Medicare articles. This is what I do during the interregnum on coverage. The problem with Medicare Advantage plans, the idea in the George W. Bush administration is to privatize medical care and to let the markets manage it, because the markets are smarter than government. And they, however, they are answerable. These private organizations are answerable to their shareholders first. That's not because they're evil. It's under the law. And so that's what their legal obligation is, to put shareholder profits above anything else. So what happens is the reason the older, sicker people will stay in UMP is that they will have more coverage. Sure, we're looking at the front end, and I agree, premiums are way too high. I agree with you, you're absolutely right. But what I've also done is an exploration of how many claims are paid. And I have heard from hospital administrators and from providers and from the people that are the billers, that it's the incentive of these private organizations to make a profit and not handle claims, not pay as much on the other end. I mean, and I got, I'll tell, I mean, Dave is going to laugh and say, she's not going to mention this again. I got an invitation to the UHC benefit presentation that was fancier than my cousin's bar mitzvah invitation, and we get fancy. I mean, all the money's, a lot of money's going to that. So, you know, if you like slam and glam and glitz, that's terrific. But I think for older people, having coverage for their condition is primary. And we're not stupid, that we're not ignorant. We know what's covered and what isn't down the road. And we're all getting older. Thank you.
Yeah, just a couple comments about that. All I would say is that, and I do get pushback about government versus not and private as well, but the people that I've talked to, a couple dozen of them that have switched over, I've been happy with the United Healthcare plan. I'll leave it at that. That's what I've been hearing back and forth as well too. And I think obviously, Ellen and folks there, you can get data on complaints and all the other good stuff back and forth. But until we get more people into the United Healthcare Complete, you know, you're going to have a tough time having apples to apples comparisons. But right now, all I can say is that eventually there's a tipping point, and eventually the politics will be trumped by the cost. And then at that point, what is Healthcare Authority going to do?
Right, right.
Alan, for bringing this provocative information forward. Elliot, again, thank you for your response. I now have a third person in line that we'd like to open up and hear public comments from. And by the way, before we move on, Alan, this will, you know, we constantly balance our mission with the margins and the resources we have to stretch. So that this conversation will continue as we continue to balance and have a choice.
Well aware of that, and thankful for Healthcare Authority for all you do.
Thank you, Alan. And I will convey that to Dave and his team. They are remarkable. Third in line is Fred Yancey. Fred, we are opening up your mic, so go ahead and comment, please. State your name and who you are. Hi, Fred. Fred, you are on mute. If you unmute, please.
The famous phrase of COVID phrase is you're on mute. Good morning, Chair Birch and members of the committee. Thank you for your work this morning. I am Fred Yancey. I'm calling today on behalf of not only school retirees, but also myself. I'm a PEB member as a retiree. And when Mr. Parton, and pardon me if I mispronounce his last name, mentioned he wanted to know if there were any other ideas, I would like to suggest that the Healthcare Authority look at seeing what it would take to offer some standalone prescription medication plans. I personally and my wife are in the Premera plan, the one that is closed, but there's an alternative Premera plan. It does not include pharmaceuticals. So we had to go on the open market to buy, do research and find pharmaceutical coverage. I think it's conceivable theoretically that if Healthcare Authority went into the field and sought proposals for offering standalone pharmacy plans, that they could do a much better deal for the average person that is availing themselves of that option. So just a suggestion, because Mr. Parton suggested that. Thank you.
Fred, thank you for that. We will note that a prescription supplemental benefit is something that's us to look into. John Parton is listening in, and Dave has written it down as well.
Thank you.
All right, I'm going to ask any other people signing in? If you haven't figured out how to sign in and you just want to open up and jump in, I'll let that for about 30 seconds. We don't see anybody signaling. We don't see any hands or mics getting unmuted. We're going to, I think, now close the public comment period. Board members, I thank you today for your participation, for your great comments, and I want to remind you that our next meeting is April 14th from 9 a.m. to 2 p.m. Dave, are there any final comments you have before we adjourn, or anything you want to tee up about agenda items for the future?
Yes, the preview of coming attractions for the April board meeting includes that second level of discussion on dental benefits with specific proposal ideas or benefit design ideas, as well as utilization and cost information. Action on the 4 resolutions that were presented and introduced today. If there's any additional information we have to share about the final conference budget that was released yesterday and any other budget provisions that we need to make you aware of, we'll have any final ledge update. And then I do plan that we will have our first executive session after the public meeting to begin talking about the rate renewal process that is undergoing, as we will have just recently received the first proposal responses from the carrier. So I do anticipate an executive session after the public session in April. And that's all I have to preview of coming attractions.
Great. It's going to be another full meeting in April. So board members, again, thank you very much. With that, I am going to adjourn this meeting, and Connie, you'll note the time. Bye all.
Thank you.
Thank you.